So we can go ahead and get started. Hello, everyone. Thank you so much for being here and for giving us this opportunity to present our work. Our project is on the LGBTQ health curriculum gaps at a public medical school that's serving underserved populations and the implications this had for mental health equity. My name is Meghna Kohli. I'm joined by my co-researchers and also co-presenters, Rihanna Bakit, Abteen Shafi, and Elizabeth Gonzalez. We're so thrilled to be able to present our findings, and we hope this serves as a catalyst for institutional change.
All right, so we wanted to open up our talk with a poll. So if you could take out your phone, and there is a QR code right here. There's also a website with the code that you can enter. We wanted to ask audience opinion, how many people identify as LGBTQ in the US? I'll leave the poll open for about 20 to 30 seconds, and then we'll move on. Okay, okay, I see some responses coming in. All right. So we're split between 8 and 10%, and then more than 10%. All right. Correct answer is 9.3%. We used Gallup. They're known for their public polling. We found that 9.3% of US adults identify as lesbian, gay, bisexual, transgender, or something other than heterosexual. Data is from 2024. Here's how they phrase the question. It seems like over time they've changed the phrasing, but this is how they currently ask it. They also include a category for other LGBTQ plus. And here we have that in 2024, that 9.3. In 2012, that number was 3.5. So the number has increased over time. Compared to 2020, 2024, the numbers have doubled. So overall, just that trend that the LGBTQ population in the US is growing. All right, second poll question. Same QR code on the left. How many hours are dedicated to LGBTQ health within medical school curriculum? We have different hour buckets. Again, I'll leave it open for like another like 20 or so seconds. All right. Oh, all right. 75% at 0 to 5 hours, 25% at 11 to 15 hours. Okay. Correct answer, 5 hours. So there was a survey of US and Canadian schools. They were able to report the median time of LGBTQ related content across the entire curriculum, and that was 5 hours. Nine of the schools reported 0 hours in the preclinical years, and then 44 schools reported 0 hours in the clinical years. So the trend or the idea here is that our LGBTQ population is growing, but their healthcare isn't being necessarily reflected in the medical school curriculum. There are not a lot of time, not a lot of hours dedicated to it.
All right, now that we've touched on some stats, I'm going to talk about considerations for the LGBTQ patient population. So we see higher rates of certain diseases, behavioral health risks, and mental health crises. Examples of this are asthma, cardiovascular disease, obesity, substance misuse, and suicide. We also see less engagement with healthcare services, patients facing clinical biases, and a lack of concordant care. So why do we see these health outcomes? So I'm going to pull from the intersectionality framework to elaborate on this. So LGBTQ women are facing a double burden of systemic bias on the basis of gender and stigma from their LGBTQ identities. And this affects the challenges that they face as they interact with the world, and it ties to those specific health outcomes we saw on the previous slide. And some further examples of this we have found from studies that women of color who identify as LGBTQ report higher levels of economic instability, food insecurity, and a lack of health insurance compared to white LGBTQ women. We also found that sexually minoritized women report significantly higher rates of depressive symptoms, perceived stress, and victimization compared to sexually minoritized men. And I'm going to turn it over to Rihanna to talk about how it looks on the medical education side.
Oh, sorry, I was muted. I think our team gave us a good perspective on like from a societal and patient population level what the LGBTQ plus identity means. And so kind of zooming into the medical education aspect of it, I'm going to talk about landscape and curricular gaps. So within the current landscape of medical education, we see explicit and implicit bias. Almost half of heterosexual first-year medical students, about 46%, express an explicit bias, while a majority, about 81%, exhibit an implicit bias against gay and lesbian individuals. Moreover, we also see that there's low clinical confidence. So only about 27% of medical students report feeling confident in their knowledge of transgender health needs, communication barriers. Students often will feel that discomfort of asking specific questions to patients about their unique LGBTQ related health needs, as well as the learning environment perception. Sexual minority students report less favorable perceptions of the medical school environment when they're compared to their heterosexual peers. So this inevitably contributes to higher rates of burnout. So looking at the curricular gaps and opportunities, as Elizabeth wonderfully highlighted, there is an insufficient instructional time of about 5 hours across US and Canadian medical schools on average. Disproportionate topic coverage as well. While most schools, about 128 to 176, teach how to obtain an inclusive sexual history, the frequency of teaching other specific LGBTQ related topics is low. And also limited representation. So there's few opportunities for LGBTQ plus patients to be treated by physicians who also have that identity. And this is because these individuals remain underrepresented amongst medical students. Okay, so next we're going to look at, our specific study. And to give you some background on our medical school, so we're from the University of California, Riverside School of Medicine. This is in inland Southern California, and it is a community-based, mission-driven school. And the mission of the medical school is to serve the underserved community in this area. Um, so, looking at our study objective and population, our aim was to identify the strengths and the weaknesses in the health curriculum through the student perspective. We had our target audience of just the UCR medical students, and students that were on leave were also included in this population. We did have institutional oversight throughout this process. This was an IRB approved study, and we obtained informed consent electronically. Next, I'll touch on the methods and the goals of this study. So this survey, to give background, this was a project 3 years in the making. The survey went through several editions with contributions from a variety of folks, including students and faculty. So the core domains that we touched on in the survey were terminology, health disparities, cultural competency, inclusivity, and clinical preparedness. The format of the survey was a 5-point Likert scale, in addition to open-ended qualitative prompts. And we distributed this through UCR's Qualtrics, and we ensured that it was an anonymous forum because no IP address data was collected. We had a qualitative and quantitative approach to analyzing the data with special emphasis on thematic analysis. And of course, with any study, we have study limitations, self-selection bias, social desirability, and ultimately that this is a single institution study. So we should be mindful when we attempt to generalize this data to other medical schools.
All right. Let me double check that I'm unmuted. Perfect. All right, I'm unmuted. So we wanted to talk about the survey. What does it include? What did it look like? There's that image on the right. This is how it would appear on the participant's phone. And some of the items that we included here on the left. How important is it to include LGBTQ plus health topics in the medical school curriculum? Another one here that we have is the UCR SOM orientation established a culture of inclusivity around LGBTQ plus issues, agree or disagree. Those are just an example of a couple that we had on there. All right, so we'll start with our quantitative results. So for our sample, it was majority first-year students at 72%, followed by MS4 at 11%, MS2s at 8%, MS3s at 6%. We did have a total of 102 responses, and notably, 25% of the responses did self-identify as LGBTQ+. This is substantially higher than current national averages of the general population, just really highlighting the importance not only for the student body, but also for future patient care. I'll have more images on the next slides, but just starting off with some results. When students were given the option to rate how pre-clerkship curriculum addresses certain areas, such as treatment considerations, say PrEP or gender-affirming care, or another area like health disparities, student perceptions were notably polarized. What do I mean by that? So we have our first visual here showing a bimodal distribution when it comes to ratings. And so when a significant portion of students think that a topic is taught well, it pops up in this yellow, green kind of chartreuse color. When students think that a topic is taught poorly, it shows up in this blue color. And you can see how it's represented in each topic. This trend continues in each of these four categories: terminology, culturally competent care, health disparities, treatment considerations. It only really truly tilts more towards poorly taught, this blue one, when it comes to terminology and when it comes to treatment considerations. Over here on the right, we have a different visual. It's on the importance of including LGBTQ plus health topics in curriculum. Over 61% of students thought it was very important to include these topics in our curriculum. On the left, we have, does UCR SOM curriculum prepare you to treat LGBTQ plus patients? Despite a lot of students saying it's very important to them to include these topics in the curriculum. Unfortunately, not many of them felt prepared to treat this population of patients. Only 18% felt that the current curriculum adequately prepared them. 28% explicitly said that they're not prepared right here, and that the majority of our responses were actually the unsure category. We suspect that this unsure category is large, most likely due to students not having a good baseline to compare how much of their medical education should include for LGBTQ health. All right. So this is our next section. It's our qualitative results. We had 4 questions where students could respond freely, our free response questions, and we got 4 themes in our preliminary data analysis. They're here in our pie chart or Pokemon ball that we have right there. So I'll start here in the yellow section in the corner. So when students were asked, does UCR SOM curriculum prepare you to treat LGBTQ plus patients? We had one student state, I haven't been instructed in how to properly care for LGBTQ plus community. Rather, I got more information during the Pride Alliance meeting. So in response to this specific question, 19 responses echoed a very similar sentiment of limited exposure to LGBTQ health curriculum. So that's our first theme. Then we're moving on here to our orange section, and the theme is faculty under preparedness, or another way to say this, or a subcategory could also be a preceptor under preparedness in the clinic setting. So when students were asked, does UCR SOM curriculum prepare you to treat LGBTQ patients? One student, and I'll just paraphrase this one student said that the preclinical curriculum really only focused on pronouns. And it was a huge missed opportunity that reflected a lack of understanding from leadership about what kind of LGBTQ health topics should be covered. Another student expressed right here that their preceptors were often underknowledged or uninterested about LGBTQ plus patients, and there were 6 responses total that echoed similar sentiments under this theme. Here in our blue, we have next theme, stigmatizing framing of LGBTQ health. One student stated that the only relevant course they had so far was in relation to STIs, and the student was concerned that it was painting them in a promiscuous manner. Another student had a similar feeling, and there were 3 responses total under the stigmatizing theme. Last thing we have here is student-led solutions. These were offered voluntarily throughout the entire free response section. One student commented that they would want repeating monthly lectures on LGBTQ plus topics, and another student mentioned that there should be a greater effort made by the school at large to find not only physicians that really want to teach, but that really want to teach LGBTQ plus health topics.
Okay, so in our study, we found that a striking 25% of the participants self-identified as LGBTQ. But to put that in perspective, that's roughly triple the percentage found in the US population. So for these students or participants, the lack of comprehensive LGBTQ curriculum isn't just an academic oversight, it's something that affects them personally. So we found that there was a direct correlation between these educational gaps and the student distress. So some of our fourth year medical students in particularly highlighted this when they talked about how it impacts me directly as being a member of the LGBTQ community. Upon looking through various studies done on this subject, we found that this actually could reflect a nationwide trend. Um, they found that sexual minority medical students reported significantly less favorable perceptions of their learning environments, which tied to higher rates of burnout. One of our participants even shared that feeling inadequately prepared to care for their own community added as an additional emotional burden. Other reports, as we mentioned earlier in our presentation, found that the median amount of time spent on this topic is just about 5 hours across 4 years. Our participants confirmed that with one MS3 stating that I can count on one hand the number of sessions that I've had. So to move from this basic awareness to clinical competency, we have to move beyond these single session models and be able to treat this education as a clinical necessity. So in our survey responses, we also found that from our first year, where more students decided a lack of diversity as the problem, to fourth year, there was an evolution where the frustration more so shifted to a lack of clinical preparedness. One qualitative study conducted with individual interviews of physicians and residents found that this theoretical knowledge is just not enough. Without hands-on simulations and standardized patient encounters, patient students are feeling unprepared when they enter a room and have to treat a sexual, gender, and minority patient. So this is consistent with research that this few disconnected lectures are not enough, and we need to integrate this longitudinally. Unfortunately, this curriculum even goes beyond what's in the handbook. So a lot of students reported that first years reported hearing inappropriate comments about this topic, and some fourth years described attendings who were uninterested in this topic. So this is further sending a message to our trainees that LGBTQ care is elective and it's not a core competency, and that further fosters harassment and this fear of being ostracized that is shared between the provider and the patient. So where do we go from here? So our first recommendation is to move away from the specialty lectures and move towards this multi-year roadmap. So what we propose is to integrate LGBTQ health topics directly into organ system blocks. So for example, when talking about gender-affirming hormone therapy, that can be discussed within the endocrinology block. Or when talking about invasive cancer screenings, that can be discussed within the OBGYN block. So this will set this education as a standard of care and not just an outlier. Secondly, addressing the culture is very important. So we want to propose potential workshops for attendings and residents to change the attitudes. We also propose enhancing our standardized patient encounters in medical schools to have scenarios where there is gender-affirming history taking. In terms of future research, the few avenues that we would love to endeavor is first, trying to track if an increased student confidence actually does improve patient outcomes over the years. Or second, if this is just a UCR issue or if this translates to other California medical education schools within the UC system. And finally, incorporating longitudinal tracking will be very beneficial. So if we could resurvey these first years when they reach third year or fourth year and see if the attitudes have changed or their experiences have changed, we can see if changes that we're making are actually making an impact. And this could be a continuous feedback loop to refine our curriculum. So finally, I just wanted to end on some barriers that we faced on student-led research. We can go through, like you guys can go through it, but essentially it was an amazing project, but it definitely took rounds of IRB approval, administrative listserv access, and challenges in increasing visibility so that students can actually participate and we can get a good opinion. And then the last slide is just our references, and then we have any questions that we can answer.
I wanted to thank the audience for listening to our presentation, and we welcome any types of questions or comments. If you want us to elaborate on something that was unclear, we can do that as well. But again, thank you for giving the time to listen to our project. We have put a lot of effort behind the scenes into what we attempt to lay out on the slides.
Similar sentiment. Thank you for responding to the poll. I really, I really appreciate that.
Thank you all for allowing us to be here and hearing about our presentation.
Yes, and we really encourage you guys to be able to uh, do similar research studies across different schools, because as we saw, this is a very important topic, and we hope that it can start the conversation and we can make real change in the medical school curriculum. So thank you guys.